I'm Peter Block here in Denver, Colorado at TCT for On the Scene, and with me is Rasha Al-Lami from London. We were talking as we were walking over here about stable angina pectoris. Important to say that, stable angina, not a coronary insufficiency syndrome where things are changing. And Rasha has done a very interesting trial concerning PCI and medical therapy in stable angina. So Rasha, tell me about the trial to start with, and tell me how it was designed, and then we'll go further with this.
Okay, so my trial is the Orbita trial. The Orbita investigators were at 5 UK centres, and we essentially took patients with stable angina and single vessel coronary disease, and patients were enrolled, had symptom questionnaires and an initial enrolment interview, and then went on to have a very intensive 6-week medical optimisation phase. They were then, at that stage, randomised to receive either a placebo procedure or a angioplasty procedure. Prior to that, they had been assessed with exercise testing and also dobutamine stress echo. The procedure was blinded, and all of those patients then entered a 6-week blinded phase in which they had no idea of their treatment allocation. Their medical providers also had no idea, and they then returned for a repeat of their baseline investigations, the cardiopulmonary exercise test and also the dobutamine stress echo and their symptom questionnaires. They were then unblinded and they returned to their usual care pathways. And the primary endpoint of this trial was a difference in the change in exercise time between the two groups.
Okay, wow, that's a lot of information. But let me just sort of point out the highlights here. Blinded actual procedure, right? The procedure was done on everyone. Some got PCI, some did not. And they were all maintained on medical therapy. Those are the two important points here. Okay, so what are the results? I mean, here we are, we've done this thing, and what'd you find out?
So what we found was that in patients with single vessel angiographically tight coronary disease and stable angina, that the ischemic markers, as assessed by IFR, FFR and dobutamine stress echo, significantly improved in the angioplasty group compared to the placebo group.
Okay, I'm going to interrupt because that's an important endpoint, isn't it? Ischemia is in fact less in the PCI group, number one.
Absolutely, but the primary endpoint, which was the difference in exercise time improvement between the two groups, was no different, with a 16.6 second difference between the groups that was not statistically significant. So while both groups improved, there was no additional improvement in the PCI arm over placebo and anti-anginal therapy.
Okay, so we've known for a long time placebo is good for patients, and this actually sort of semi-proves that, doesn't it?
So the placebo effect is part of our therapeutic effect. As doctors, we know that the more engaged we are with our patients, the more we tell them about what we're about to do, and the more definitive we are with our treatment, the better they feel. And so clearly the clinical effect that we see with angioplasty and stable angina is contributed to by a combination of the true physical effect and a placebo effect.
Okay, now I'm going to ask you a difficult question. As you see your patients that have stable angina, what do you tell them about whether or not they need a PCI, knowing these data?
So I think these data inform our consent process. We can now tell our patients that we have placebo-controlled data of their symptomatic and functional improvement after angioplasty. I can tell them that I know that angioplasty will improve the blood supply to their heart, but then in terms of symptom improvement, the symptom improvement is much the same as placebo plus intensive anti-anginal therapy. Now for some of our patients, they won't want to take high-dose anti-anginal therapy for the long term, and we may have a discussion about the alternative of a procedure that has a small risk but potential benefit for them.
And it is important to point out this is not a prognostic trial. This has nothing to do with whether or not these patients have something happen down the road.
Absolutely. So this was purely to test whether symptom relief and functional improvement occurs as a result of angioplasty in stable angina patients, and it's for larger trials to look at the prognostic benefits.
A fascinating trial. Thank you.